welcome to another engaging episode of MedSynapse podcast series. I'm your host, Hetvi Shah, and today we're exploring a connection that is not talked about enough, which is how rheumatological diseases can silently impact lung health. While joint pain and inflammation can take center stage, lung complications can be just as serious, often going unnoticed until they become very serious. And to help us navigate this crucial intersection of rheumatology and pulmonology, we have with us Dr. Zubair Ashraf, an expert pulmonologist with over 15 years of experience across Pakistan, the UK, and Europe. Beyond treating patients, he is deeply involved in medical education and mentoring young doctors. So, Dr. Zubair, it is such a pleasure to have you on the show and welcome to the show today.
Thank you, Hetvi, and I am thankful to MedSynapse as well for giving me this opportunity to discuss about this pulmonology topic on their platform. Thank you.
Thank you, Doctor. So, Doctor, before we jump into our topic, can you give us a brief introduction about yourself and what actually interested you in pulmonology?
Okay, yes. So, obviously, you already have introduced me, so thanks to you. And pulmonology, I was interested in pulmonology because it's a very diverse type of field, and you have to have interaction with other specialists like cardiologists, nephrologists, general physician, intensive care, ICU doctors, emergency physician. So, and there is a wide variety of patients. We get patients who have got infections, who have got airway diseases, who have got pleural diseases, cancer. So, due to this diversity of patients and diversity in interaction with other colleagues and other specialties, I got interested in pulmonology.
Yeah, that's very interesting to hear. Now let's start with a big picture. Pulmonology involvement in rheumatological diseases is often overshadowed by joint and systematic symptoms. So based on your experience, how common are these complications and why should physicians pay closer attention to them?
Yes, so rheumatological diseases, as we all know, they are multi-system diseases. Like in addition to the joint involvement, there is the involvement of other system as well. And pulmonology or the respiratory system is one of the most commonly involved system which is affected, what we call as extra articular involvement in these diseases. So that is the reason why it is very important to not only screen these patients for pulmonary symptoms, but also we need to keep a good eye, close eye for these symptoms, because once there is pulmonary involvement, unfortunately, the prognosis of these diseases that become worse as compared to patients who do not have pulmonary involvement. So these patients, they get more sick, they have more debilitating symptoms. Obviously, they are already suffering from the joint symptoms, but when there are pulmonary symptoms like shortness of breath, like chronic cough, and other symptoms, then they start to suffer more from these symptoms. So it is important to recognize these symptoms early, and these symptoms should be investigated as early as possible so that treatment can be started, and if possible, these symptoms should be and these problems should be treated. And in some cases, when this is not possible, at least the progression of the disease should be slowed.
That's actually an eye-opening answer, Doctor. Now let's talk about specific conditions, like which rheumatological diseases most commonly lead to pulmonary involvement, and what is happening at a mechanistic level, if you could tell us.
Okay, so we will start with the most common rheumatological disease, which is rheumatoid arthritis. Rheumatoid arthritis, in rheumatoid arthritis, there can be a wide variety of pulmonary involvement. There can be pleural effusion, there can be interstitial lung disease, and the interstitial lung disease can be of various types. Then there can be pulmonary nodules, the rheumatoid nodules, which we call as, and there can be involvement of the airways, there can be involvement of the muscles. So there are multiple type of involvement in rheumatological disease, in rheumatoid arthritis. And uh, so the important thing is to recognize this involvement. Let's take the involvement of the parenchyma, which is the interstitial lung disease in rheumatoid arthritis. Uh, so the involvement is highly variable. In some patients, it is very mild, and some patients may not have any symptoms of this involvement. But in other patients, it can be severe. So, depending upon what criteria we are using for screening, for example, HRCT, if we are doing in all the patient, in even in asymptomatic rheumatoid arthritis patient as well, then HRCT can pick up pulmonary involvement in up to 50% of the cases. And according to some studies, even 80 to 90% of cases who have rheumatoid arthritis, the pulmonary involvement can be seen on autopsy. So there is a huge variation depending upon what criteria or what instrument you are using to screen for pulmonary involvement. The symptomatic or significant involvement is usually seen in around 10 to 15% of the cases of that is of interstitial lung disease. Then the interstitial lung disease can be of multiple types in rheumatoid arthritis. The most commonly seen pattern is what we call as UIP pattern, usual interstitial pneumonia, which is similar to what is seen in IPF or idiopathic pulmonary fibrosis. Although other patterns like NSIP, non-specific interstitial pneumonia, and organizing pneumonia, they can also be seen in rheumatoid arthritis. And then, as I told you earlier, that extra, other than the parenchymal involvement, like pleural effusion is also common in rheumatoid arthritis, which is in the form of lymphocytic exudative effusion, pulmonary nodules, which are usually asymptomatic. So they may be incidentally discovered when the patient undergoes imaging of the chest for any other reason. So these are the main types of involvement of respiratory system in patients of rheumatoid arthritis. And then if we move on to the next common rheumatological disease, which is SLE, systemic lupus erythematosus. Really, more commonly involved is the pleural, which the pleura, the pleuritis, and the pleural effusion. They are more commonly involved as compared to parenchymal involvement, and the incidence of pleural effusion is more as compared to rheumatoid arthritis, while the incidence of connective tissue disease related ILD in the pattern of non-specific interstitial pneumonia. Similarly, if we talk about systemic sclerosis, in systemic sclerosis there are two types: diffuse and limited. So in these cases, we can see interstitial lung disease, as well as we can see pulmonary hypertension as well. So roughly speaking, around 10 to 15% of cases of rheumatological disease, they present as interstitial lung disease.
So like it's like a mix of immune mediated and direct lung damage. So it makes like early detection.
Yes. So if we talk about the pathophysiology behind this, in rheumatological disease, these are called as autoimmune disease. Though the defense system, the immune system of the body starts acting against the body itself. So similarly, in pulmonary involvement, in lungs, there is alveolar damage. There is an alveolar damage due to involvement of the cytokines. Different mediators are released due to the basic pathogenesis of these rheumatological conditions, and these damage the lung. There is diffuse alveolar damage, and sometimes they can cause diffuse alveolar hemorrhages as well. And when this damage is repaired, body repeated repair leads to fibrosis, and which manifests as interstitial lung disease.
Yeah, so at what stage, like a rheumatologist or pulmonologist start screening for lung involvement in patients with these autoimmune diseases?
Okay, so the screening for pulmonary involvement should start at the time of the diagnosis. When the patient presents to the rheumatologist or pulmonologist or even any general physician as well, and they are suspected to have rheumatological diseases, at that time they should be screened for pulmonary involvement as well. So, how screening is done? The best way to screen, first of all, we need to ask about the history. Most commonly, these patients will have history of dry cough. They will have history of shortness of breath, chest pain, and sometimes they only have atypical symptoms or general symptoms like fatigue or fever or weight loss. But these symptoms can be the underlying symptoms of respiratory involvement as well. So, starting with symptoms, examination finding will also point towards the involvement of the respiratory symptom. And then we will have to move to investigations. The screening investigation, usually chest X-ray is done, but chest X-ray can be normal in early pulmonary involvement. So, if the suspicion of respiratory is chest, which is able to pick up early initial lung disease and other early abnormalities, smaller abnormalities as well. Then pulmonary function test, which includes spirometry, lung volume measurement, diffusion capacity, alveolar. If we talk about spirometry, there will be restrictive defect. Even FVC is normal or increased, and the lung volumes are reduced, total lung capacity is reduced, residual volume is reduced, functional residual capacity is reduced as well. So all these findings will point towards the involvement of the respiratory symptom system in these cases. And again, then 6-minute walk test can also be done, which is a good screening tool as well for early interstitial lung disease. In case of if even if chest X-ray is normal, if there is desaturation, drop in oxygen saturation on 6-minute walk test, that will also point towards the involvement of the respiratory system. And why this early screening? As I said, it should be done on first visit at the time of diagnosis. Why it is important? It is important, as I said earlier, because whenever there is pulmonary involvement and rheumatological conditions, the prognosis of the patient becomes poorer. So, an early diagnosis of respiratory involvement will lead to early intervention, early start of treatment, which can help these patients. After the diagnosis, whenever the patient is followed up, like mostly these patients are followed up on 6 months interval once they have achieved a stable disease, then again, similar screening should be done, starting with history, physical examination, and if needed, investigation. And once respiratory involvement is confirmed, then 6 months to 1 year, their pulmonary function test, and if needed, HRCT test should be repeated. Thank you.
Yes, that makes a lot of sense now, doctor. But another question is that when lung damage has already progressed, patients often struggle with pulmonary fibrosis. So, what are the best strategies to improve their quality of life?
Okay, so first of all, again, an effort should be made to diagnose this patient early so that it does not reach the stage of pulmonary fibrosis. Because first there is inflammation, then repeated inflammation leads to fibrosis. In some types of interstitial lung disease, like UIP pattern, there is fibrosis from the start. While in other, like non-specific interstitial pneumonia and other type of ILDs, there is usually cellular inflammation, ground glass opacities on HRCT. So in those cases, we can delay or stop stop the progression to the fibrotic stage. But once fibrosis is developed, it is already there. Then obviously continuation of the treatment of the underlying ILD, which is usually with steroids or immunosuppressants, that should be continued. And now we have got availability of antifibrotics. Antifibrotics, they delay or they slow down the progression of fibrosis in these patients. Nintedanib has been approved. Similarly, we have got pirfenidone, which can be given in these patients, which although does not reverse the fibrosis, but it slows down the further progression. In addition to that, these patients should be protected against repeated infection with vaccinations. Flu vaccination every year and pneumonia vaccination should be given, and COVID vaccination and other necessary vaccinations should be given to these patients so that they do not get recurrent infections, because in these cases the infection can be devastating and it can lead to further worsening of the fibrosis or further worsening of the respiratory disease. So vaccination is the second thing which is important. Then if they are needing oxygen, they should be given oxygen. If they fulfill the criteria, they are desaturating on rest or on exertion, so appropriate oxygen therapy should be given. And if there are any comorbidities, those should be treated. For example, if they have got heart failure along with that, that should be treated. And then there is role of pulmonary rehabilitation. Pulmonary rehabilitation usually done in COPD patient, but it has its role in interstitial lung disease. They should be encouraged to do exercise, to stay active as much as they can, and if needed, other modalities of pulmonary rehabilitation like good nutrition, physiotherapy, counseling, that should be utilized as well.
Yeah, so I think pulmonary fibrosis seems like a multifaceted challenge also, and I think multidisciplinary teams also helps in that.
Whenever there is involvement of respiratory system and in rheumatological diseases, the management is always multidisciplinary. It involves rheumatologist, it involves pulmonologist, radiologist, pathologist. If there is pulmonary vascular involvement with pulmonary hypertension, then cardiologists are also involved. And then, as I said, physiotherapist, occupational therapist. These are all involved in the treatment of and management of these patients.
Yes, absolutely. So now one question that often arises is how do treatment approaches for pulmonary complications in rheumatological diseases differ from those used for primary lung conditions?
Okay, so now the interstitial lung, let's take the example of interstitial lung disease. When the interstitial lung disease can be idiopathic, then when that means that it is not due to any other factor or any other cause, or it can be due to connective tissue disease. In connective tissue disease related interstitial lung disease, there is more role of steroids and immunosuppressants as compared to primary interstitial lung disease without any obvious cause. And overall, there is more. It is thought to be more steroid responsive. The ILD related to connective tissue disease is thought to be more steroid responsive. So usually treatment is first with steroids at the time of the diagnosis, and if there is an exacerbation, high dose steroids are given, and depending upon response, they are slowly tapered off. If patient cannot take steroids, or if patient is not responding to steroids, or if patient is having side effect to steroid, then immunosuppressants are added. Immunosuppressants usually which are used are cyclophosphamide, mycophenolate, and azathioprine are usually used. Methotrexate is another one. But again, we have to be careful because we have to balance the risk with the side effects. All the immunosuppressants and steroids, we all know that they have got some serious side effects. So patient education is important. Patient should be explained that these are the medicine we are starting you on, and you can have these side effects. So they should be aware of the side effects, and they can report back to the doctor as soon as they get any side effect, and then the treatment needs to be modified. So steroids, immunosuppressants, and then there is role of biological agents or monoclonal antibodies, which are now very commonly used in treatment of rheumatological diseases. and they are obviously, whenever there is pulmonary involvement as well, they are more commonly used as well. They have got lesser side effect, and dosing is also not that frequent, so they are more coming into favor more and more now. And so basically, in summary, the treatment of pulmonary disease in rheumatological condition is basically focused on the treatment of the rheumatological disease itself. So it is done in agreement with the rheumatologist and the pulmonologist, and patients are monitored. Usually, these patients remain in follow-up with both pulmonologist and rheumatologist. As I said, patient education is important, and then eventually, if the disease becomes very, very progressive, patient develops respiratory failure, then there is an option of lung transplant, which can be considered as well.
Interesting distinction, Doctor. Now, Doctor, before we wrap up, any final thoughts or key takeaways for physician managing these such cases?
Yes. So, as I said earlier, it is very important to be remain vigilant about pulmonary involvement in rheumatological disease. As I said earlier, the screening should be done whenever there is any interaction, any follow-up at the time of diagnosis. Screening should be done with good history, clinical examination, and if needed, go for HRCT test, pulmonary function test, a 6-minute walk test. That should be able to help you in diagnosis of these condition, because early diagnosis is very, very important. Similarly, it is important that history and clinical examination is used in these patients, and the treatment is done as a multidisciplinary team, involve other specialists if needed.
Thank you so much, and this has been an incredibly informative discussion. So thank you so much for actually sharing your insights and expertise and shedding light on an area that is that truly deserves more attention. So thank you so much, Doctor.
Thank you for having me.
And to our listeners, thank you for tuning into yet another episode of MedSynapse podcast series. And remember, if you're a healthcare professional who's eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay informed and stay healthy. Thank you.